Welcome back to the Explainer, everyone. Today, we are decoding the exact spatial geometry of two highly specialized skull views. We're mastering radiographic protocols, specifically breaking down the positioning, angles, and evaluation criteria for the Haas and the SMV skull projections. You know, if you've ever felt like setting up these specialty views is kind of like solving a giant 3D puzzle, well, you're in exactly the right place. We're going to figure out exactly how to capture all that hidden anatomy. But first, let's set the stage with a very real clinical dilemma. Picture this. You're on shift, you get an order for a skull series, and you absolutely need to see that occipital bone clearly. Usually, you'd go straight for the apiaxial, right? The classic Townes method. But what if your patient simply cannot do the Townes view? It's actually incredibly common, especially when we're dealing with hypersthenic patients who might just physically struggle with that extreme neck flexing you need for the standard AP approach. So, what's your plan B? Okay, let's dive into this, because your plan B is the Haas method. The Haas method is honestly the hero for this exact patient scenario. It's a PA axial skull projection that shows the exact same anatomical structures as the Townes method, specifically targeting that occipital bone you're after, but it approaches the skull from the completely opposite direction. It's just a fantastic real-world workaround for those hypersthenetic patients. So here's our clinical roadmap for today's explainer. Number 1, the Haas method protocol. Number 2, evaluating the Haas projection. 3, the SMV skull protocol. And finally 4, evaluating the SMV projection. All right, section 1, the Haas method protocol. Let's get right into breaking down the physical positioning setup. Let's look at the actual positioning steps for the patient and the part. Step 1, you want to position your patient either prone or seated in an upright PA position. You also want to make absolutely sure their shoulders are laying in the exact same horizontal plane. Step 2, center the mid-sagittal plane directly to the middle of your image receptor, or IR, making sure that mid-sagittal plane is completely perpendicular. Now, step 3, this is where the magic happens. You need to flex the patient's head until the orbital medial line, the OML, is perpendicular to the IR. That specific flexion is absolutely critical for setting up our central ray alignment, while, of course, maintaining your collimation borders of 1 inch all around the skull. And that brings us to the magic number 25. Once you've got that orbital medial line strictly perpendicular to the IR, your central ray must be directed exactly 25 degrees cephalad to the OML. This is the precise angle required to throw all those facial bones completely out of the way and project the occipital region clearly onto your image receptor. And this brilliantly illustrates the exact geometric roadmap for that central ray. We know the angle is 25 degrees cephalad, but where exactly does it go? Well, step 1, the beam needs to enter at a point 1.5 inches inferior to the external occipital protuberance, otherwise known as the inion. Step 2, it should exit approximately 1.5 inches superior to the nasion. And finally, step 3, always remember to have the patient suspend their respiration before you make the exposure. We definitely want to prevent any motion artifact. Moving on to section 2, evaluating the Haas projection. Let's shift over to the quality control phase on the monitor. Okay, here is your ultimate pass-fail checklist for this view. First up, you need to see the entire cranium with 0 rotation or tilt. The mid-sagittal plane of the cranium has to be aligned perfectly with the long axis of your collimated field. But how do we actually prove there's no rotation? Look at the second point. You must see equal distances from the lateral borders of the skull to the lateral margins of the foramen magnum on both sides. Third, we're looking for perfectly symmetric petrous pyramids. And lastly, to confirm that our 25 degrees cephalad angle was spot on, we must see the dorsum sellae and the posterior clinoid processes projected squarely within the foramen magnum. If you've got all of these, congratulations, you've got a successful Haas projection. Section 3, the SMV skull protocol. Let's shift gears from the occipital bone over to the submental vertical setup to evaluate the petro-C. So, SMV. That stands for submentovertical. As the name implies, the X-ray beam is going from right under the chin, the mentum, straight up through the top of the head, the vertex. Our source material notes a highly practical tip here. Trying to do this in an upright, seated position is actually much more difficult than a supine position. When they're supine, the patient's head needs to be hanging off a radiolucent sponge to get that mid-sagittal plane perpendicular to the IR. You'll also want their shoulders in the exact same horizontal plane. And here is a fantastic comfort technique for you. Keep their knees flexed. Flexing the knees actually helps to relax the abdomen, which is crucial because this position requires some serious flexibility. We're doing radiology here, but honestly, it might feel a little bit like yoga for the patient. The whole reason they need that flexibility is right here, the IOML, or infraorbital medial line. This is your absolute key radiographic landmark for the SMV. To position the part correctly, you must have the patient extend their neck backwards until the infraorbital medial line is strictly parallel to the IR. At the same time, the mid-sagittal plane of the head must remain exactly perpendicular and centered to the IR. Getting that IOML totally parallel requires full maximum neck extension, which is exactly why relaxing the abdomen by flexing the knees really helps the patient tolerate the stretch. Now, once you have that full neck extension with the IOML perfectly parallel to the image resector, setting your central ray is actually pretty straightforward. The CR is directed perpendicular to the infraorbital medial line. It enters the mid-sagittal plane exactly 3/4 of an inch anterior to the level of the external acoustic meatus. And hey, just like with the Haas method, remember to have the patient suspend their respiration. You really want to keep them completely still in this awkward position. Your collimation borders here are going to remain 10 by 12 vertical with 1 inch all around the skull. Now, what's really interesting about this slide is how it contrasts the two drastically different geometric approaches we've just mapped out. On one side, the Haas method relies on the OML being perpendicular to the IR, requiring that 25-degree cephalad angle to compensate. On the other side, the SMV method relies on maximum neck extension to get the IOML completely parallel to the IR, which then allows for a straight, perpendicular central ray. It's two completely different setups, utilizing two different baselines, the OML versus the IOML, to unlock totally different hidden areas of the skull. So how do we actually know if we nailed that maximum neck extension? Section 4, evaluating the SMV projection. Just like before, we're going to start with our baseline evaluation criteria. You want to see the entire cranium without any tilt or rotation whatsoever. To verify there's no rotation, you need to check for equal distances from the lateral borders of the skull to the mandibular condyles on both sides. And of course, the primary goal of this entire projection, you absolutely must see beautifully symmetric petrosi. So the crucial point is right here. How do you clinically prove on the radiograph that the patient actually achieved full neck extension and that the IOML was truly parallel to the IR? Well, the image holds the proof. First, you must see the mental protuberance, that's the chin, superimposed perfectly over the anterior frontal bone. Second, you must see the mandibular condyles projected anterior to the petrosi. If you're looking at the image and the mental protuberance is sitting way too far posterior, or the condyles are superimposing the petrosi, well, your patient's neck just wasn't extended enough, and that IOML wasn't parallel. We've definitely covered a lot of exact angles and spatial baselines today, right? From that 25-degree cephalad angle of the Haas all the way to the pretty challenging neck extension of the SMV. So, I'll leave you with this final question. How will mastering these precise geometries unlock the hidden anatomy of the skull on your very next clinical shift? Because the next time you have a hypersthenic patient who just can't flex for a Townes view, you now have the Haas method right there in your toolkit. Knowing exactly how to manipulate the OML and the IOML literally turns a difficult exam into a totally successful one. Thanks so much for joining me on this explainer, and keep exploring those fascinating geometric puzzle pieces of human anatomy.